Hello everyone and welcome to PW Meded. So we're continuing our rapid revision series for the upcoming FMGE exam. Please pardon my voice. I'm not kind of keeping well. I hope the voice clarity doesn't bother you much. We will try to focus on what is important for the upcoming exam. Because when it comes to FMGE, right now, because very limited time is there, I think we need to be very much concentrated on the key topics and not the elaborative learning. So for those who want a detailed learning of the topic, yes, we will be addressing it again after the FMGE exam with another series. This is mainly for the exam going students and the focus is on extremely high yield topics. So what are the important topics? According to me, the tone, deep tendon reflexes, these are basics, I know, but repeatedly they have been asking questions on it. Differentiation between upper motor and lower motor neuron lesions, an important topic. Localization of lesions in neurology is an important topic. Three important topics apart from this, the core topics are GB syndrome, myasthenia gravis, aphasia and movement disorders, primarily focusing on tremors, right? So first we will address the core topics, the important ones, the tone, deep tendon reflexes and differentiation between upper and lower motor neuron lesions. I know neuroanatomy is difficult and you may not be able to understand this if you're fresh, or even if you're read it once, it might be still a difficult topic. So what we will do is we will quickly go through the basic organization of the nervous system and then we will get back to this point. So when we look at the organization of the nervous system, there are two ways we can discuss the nervous system. One is the anatomical organization, which primarily divides the nervous system into central and peripheral nervous system. In central nervous system, we have the brain and the spinal cord. And in the peripheral nervous system, it can be divided as somatic and autonomic. In the somatic, we have the cranial nerves and spinal or peripheral nerves. And in the autonomic side, we have sympathetic and parasympathetic nervous system. This is the anatomical organization. There's also another way of looking at how the nervous system functions by dividing it into functional organization. Function-wise, our nervous system does three important functions. One is the motor function. When I say motor function, what does that mean? Movement, right? Movement of body parts, which can either be voluntary or involuntary, right? There are a lot of movements that happen in the body are involuntary, like the blinking of eyes when we are walking, swinging of arms. They're all involuntary body movements. Apart from that, plenty of movements are voluntary, right? Most of the things. Now I'm talking to you, I'm moving my hands, it's a voluntary movement, right? And then it has another function, which is sensory function, where we perceive the sensation and then brain deciphers what sensation it is, right? The sensory system is divided into two groups: the peripheral sensations, which are also called as primary sensations, and cortical sensations, which is mainly the function of the brain. Okay, so normally what comes under this peripheral sensation? Simple sensations like touch, pain, temperature, vibration and joint position. These are all counted as peripheral sensations. Like I touch, you can feel it, right? If I give you a painful pinch, you can feel the pain. If I touch you with a hot or cold object, you can feel its temperature. If I put a vibrating tuning fork or any other vibrating object on your body, you will feel the vibrations. And if I ask you to close your eyes and put your joint in a flexed or extended state, you will be able to tell without looking at your fingers or body parts whether the joint is in a flexed state or in an extended state. That is what we call a joint position sense. Now, taking these same sensations, your brain tries to process it further and it can give you some higher dimensions of sensation. Those sensations are called as cortical sensations. That includes stereognosis, graphesthesia, tactile localization and all, including the 2-point discrimination. Right. Now, what is stereognosis? Your ability to identify the three-dimensional shape of an object. Like if someone hands over a sphere or a cube, you will be able to hold it in your hand with your closed eyes and you can tell this is cube or this is a sphere, this is a cylinder, right? How are we able to identify that? Because you're able to feel the touch, you're able to feel the temperature of the object, and your body is deciphering different joint positions, right? Each joint, while holding the object, might be taking up different angles. So your brain interprets the position of different joints, touch and temperature data to tell you what object you are holding in your hand without looking at it. This sensation is what we call as stereognosis. If I write a letter on your skin, you will be able to feel it. You can say that you wrote letter L, you wrote letter A. This sensation is what we call as graphesthesia. And if I touch you, when your eyes are closed, you can specifically pinpoint which part of the body was touched. This sensation is what we call as tactile localization. All of these come under cortical sensations. They come under cortical sensations. Okay. Apart from the peripheral, the sensory sensations and the motor functions, brain also does what is called as higher mental functions, which is also called as cognitive functions. Means our ability to think, right? Reasoning, social behavior, memory, all of that comes under this cognitive functions or higher mental functions. This is a function that our brain does. Voluntary movements, feeling the sensations, and higher mental functions. Okay. So with this backdrop, I will focus your attention to the motor system on voluntary functions, right? So motor system, when we say voluntary, there are two important systems which help us to do a coordinated movement. That includes the pyramidal system and the extrapyramidal system. Okay, pyramidal system is the main one here, which helps us to do the voluntary movement, and the pyramidal system begins with the cortex, right? So in the cortex of the brain, just anterior to the central sulcus in the frontal lobe, there is an area called as motor area. You can also call it as motor cortex. That is where the initiation of the movement happens. Okay, how do we initiate the movement? This motor area is nothing but a collection of cell bodies of neurons, right? Millions of neurons, their cell bodies are all collected here in the motor cortex. Those who have followed me from the beginning, you probably know that whenever I use the term cortex, area, ganglion, it all means, or including nucleus, it means that we are talking about collection of cell bodies. So when I take a sagittal section here, right, this is how the brain is going to look like. So in the motor cortex, we have all these cell bodies. The cell bodies is what we call as pyramidal cells or the bed cells. Okay, these are the cells which initiate a voluntary movement. But obviously the cell bodies cannot directly talk to the muscle, right? They have to send an axon. So these axons coming from these pyramidal cells or bed cells form a tract. This tract is what we call as the pyramidal tract. Okay. Now, this journey of the pyramidal tract is important for us to understand various issues in neurology. How the axons originating in the motor cortex reach its destination, which is a muscle, right? A muscle is the one which is responsible for the voluntary contraction. So these cell bodies send their axons down. The axons form the pyramidal tract. They descend on the same side. From the cortex, they enter the subcortical region. Then they enter the brainstem. And at the lower end of the brainstem, which is nothing but medulla, right? At the lower end of the medulla, they cross over to the opposite side. This is what we call as the pyramidal decussation, because the pyramidal tract is crossing over to the opposite side. We call it as pyramidal decussation. This is an important MCQ. What is the site at which the pyramidal tract decussates? It is the lower medulla, right? Lower end of the medulla, it is crossing over to the opposite side. Started in the motor cortex, the axon is traveling all the way down to the lower end of the medulla, crosses to the opposite side and enters the spinal cord. Once it enters the spinal cord, it continues. These axons continue to descend down till their respective spinal segment comes. And once their respective spinal segment comes, these neurons move into the center of the spinal cord. The center of the spinal cord has the gray matter, right? So in the gray matter, whenever we say gray matter, again we are talking about collection of cell bodies. So there will be collection of cell bodies. There will be collection of cell bodies of motor neurons. We call these cells as anterior horn cells. We call them as anterior horn cells. Why we call them as anterior horn cells? Because when I take a cross section of the spinal cord here, the cross section looks like that, right? Core or within the spinal cord, we have this gray matter arranged like a butterfly shape, and the outer side we have this white matter, right? So tract is running in the white matter. The tract is running here, the white matter, the pyramidal tract. Center is what? We have the gray matter. So the axon comes in this tract, moves into the gray matter, and then synapses with another cell body in the gray matter. So this cell body is what we call as the anterior horn cell. Obviously, this cell body will also have an axon which comes out of the spinal cord. It comes out of the spinal cord as a spinal nerve, and it continues its journey till it reaches the neuromuscular junction and hands over the signal to the neuromuscular junction, and thus we end up contracting the muscle. That is how we achieve the voluntary movement. So for us to achieve this voluntary movement, how many neurons we required? 2. The one that started in the brain and continued all the way to the spinal cord till it reached its respective spinal segment, that is first one. Second one that started in the spinal cord and reached all the way to the neuromuscular junction, that is the second one. The first neuron is what we call as the upper motor neuron, means cortex to the spinal cord, and from the spinal cord the anterior horn cell to the neuromuscular junction is what we call as the lower motor neuron. I hope we have the clarity what is upper motor neuron and what is lower motor neuron. Now the question is, what are the functions of these upper and lower motor neuron? One function which is shared by both upper and lower motor neuron is very clear. Whenever we want to do a voluntary movement, signal will be initiated by the cell bodies in the motor cortex, and then upper motor neuron, the axon, takes that signal to reach the respective spinal segment and hands over to the respective lower motor neuron. Respective lower motor neuron picks up that signal and hands over to the neuromuscular junction. That is why they are playing an important role in the voluntary function. But apart from that, they do two more important functions, right? So first let me talk about this lower motor neuron. Apart from taking the signal from the upper motor neuron and then passing it on to the lower motor neuron, neuromuscular junction, lower motor neuron continuously keeps sending the signal to the neuromuscular junction so that the muscle is in a partial state of contraction. This partial state of contraction of the muscle is what we call as tone. So now tell me, who is responsible for the maintenance of the muscle tone? It is lower motor neuron. But if lower motor neuron sends too much signals, then the muscle will, instead of being a partial state of contraction, it will completely contract. So to avoid that, someone has to keep a check on that. Who is keeping the check on that? It is the upper motor neuron. Upper motor neuron suppresses the lower motor neuron when it comes to the maintenance of tone, so that they find a balance. Lower motor neuron keeps sending the signal to the muscle to be in a state of contraction. Upper motor neuron suppresses so that we only achieve a partial contraction of the muscle. That is what we call as tone. Okay. The second thing is, it plays an important role in the reflexes. Right? When I say reflexes, there are plenty of reflexes. Let me concentrate on what is important for the exam, that is deep tendon reflex. Okay, see, forget about deep tendon reflex. Now if I touch a hot object, I will quickly withdraw my hand without even thinking that, oh, I have touched a hot object and I need to withdraw, because it is a reflex. I don't need to have a thought process. After I have withdrawn my hand, then I realize, oh, I touched a hot object. Right? So how this reflex works? One thing is very clear, that the thought process is not involved in withdrawal. Right? It's not a voluntary reaction that I did. It happened as a reflex. So to maintain this reflex, there is something called as a reflex arc. Okay. So what is there in the reflex arc? A sensory input, and see, what I touched hot object. So what I received was a sensory input. What was the reaction? Withdrawal of my hand. That is a motor response. A sensory input is converted to a motor response. So this conversion happens at the spinal cord level itself, and brain plays very minimal role. So when a sensory object, a sensory stimulus is given, like pain, painful, pinch, or exposure to hot, the signal travels to the posterior horn of the spinal cord through the peripheral nerve. Okay, the sensory neuron takes it to the spinal cord, posterior horn, and then it hands over that signal to another neuron which is called as interneuron. It is called as interneuron, and this information is now picked up by the anterior horn cell. Right? Where did we talk about anterior horn cell? It is nothing but the cell body of lower motor neuron. Now the lower motor neuron sends the impulse to the muscle to contract. That is how the reflexes are exaggerated. Like reflexes are exhibited. Now, if I think we clearly understand that lower motor neuron is playing an important role in the reflexes, right? But if I touch a hot object, the reaction should also be proportionate, right? I can't be like, okay, I touched a hot object and I fly in the air. No, not possible, or should not happen, right? So someone is also suppressing this reflex so that we have a middle ground. Who is suppressing this reflex? It is the upper motor neuron. So lower motor neuron is responsible for maintaining the muscle tone, and it is responsible for the reflexes, and upper motor neuron is suppressing both of these activities. Clear? Okay. So now if I do damage to lower motor neuron, what will happen to the reflex? It is the lower motor neuron which is a part of the reflex arc. So if I damage it, the reflex will get diminished or depressed. Clear? Or it may get absent. Then what about the tone? It is the lower motor neuron which is continuously sending the signal for the muscle to be in a partial state of contraction. No more signal, the muscle will not be able to maintain the tone. So whenever there is damage to lower motor neuron, reflexes become diminished and the tone becomes diminished. Okay, but what if I do a damage to upper motor neuron which is actually suppressing the lower motor neuron? If I damage it, then now there is no more suppression, right? No more control on the lower motor neurons activity. So then what will happen to the reflexes and the tone? Upper motor neuron is responsible for suppressing the tone, suppressing the deep end reflexes. I remove the suppression, the tone will increase. The reflexes will become exaggerated, right? So the difference between UMN lesion and LMN lesion is pretty simple. When it comes to tone, when there is damage to upper motor neuron, suppression is gone, tone increases. We develop hypertonia. In this specific case, we call it as spasticity. I will discuss more about the difference between spasticity and rigidity later. Okay. Second, damage to lower motor neuron. The tone will decrease. This is what we call as flaccidity, right? Then deep tendon reflexes, damage to upper motor neuron, the suppression is gone, reflexes will become exaggerated. This is what we call as hyperreflexia. And if there is damage to lower motor neuron is responsible for reflexes. So there is a damage means we will have hyporeflexia or areflexia. Reflexes are abolished or diminished. There is a third feature that will help us to differentiate between UMN lesion and LMN lesion. That is the plantar reflex, the Babinski reflex that you study. So in case of the damage to upper motor neuron, when you try to elicit the plantar reflex, it becomes extensor response. Now what is there in the extensor response? Extension of great toe and fanning out of other toes. So when you try to elicit the plantar response, if there is a damage to upper motor neuron, the great toe becomes extended and the other toes become fanned out. That is the response. This is actually an abnormal response. Okay, abnormal response which is seen when there is a damage to upper motor neuron. When there is a damage to lower motor neuron, you get a flexor response or no response. Mute plantar reflex or a flexor reflex. Now what is this flexor reflex? When you try to elicit the plantar reflex, the great toe goes into flexion and the other toe becomes more crowded. This is what we call as the flexor response. There is one last point that will help us to differentiate UMN and LMN, that is atrophy and fasciculations. Atrophy and fasciculations. Now what do I mean by atrophy and fasciculation? I have a patient with damage to UMN, I have a patient with damage to LMN. Okay. Which patient is likely to have severe atrophy and fasciculation means twitching of the muscles? It is the lower motor neuron damaged patients will have atrophy and fasciculations. Atrophy and fasciculations. Why? Because tone is what? Partial state of contraction of the muscle. So if I have tone, see, we all know that the more the muscle contracts or does the work, more bulk it builds, right? It becomes hypertrophied. So when I say tone, that means my muscle, even when it is not doing a voluntary contraction, it is still in a state of contraction. That partial state of contraction is what we have called as tone. Lower motor neuron is maintaining it. So that means even when I am not flexing my biceps, right? It is completely relaxed. My biceps is partially contracted. That is normal physiology. So it means it is now also working out, right? It is doing some activity that helps it to maintain the muscle bulk. But if the tone gets diminished, then there is no work done by the muscle. So the muscle mass starts decreasing. That's why we get atrophy in patients with lower motor neuron damage. So please keep in mind, whenever you see atrophy and fasciculations in any patient, first thing that should come to your mind is this patient has got damage to lower motor neuron. And it simply means that where is the lower motor neuron found? Gray matter of the spinal cord to the neuromuscular junction through the peripheral nerve, right? So most likely either the gray matter of the spinal cord has the damage or the peripheral nerves have the damage. If a patient has got hypertonia, hyperreflexia, extensor plantar response, then that means there is a damage to upper motor neuron. And where do I find the upper motor neuron? Brain, subcortex, right? Brainstem, then spinal cord. Damage must be in the spinal cord or the brainstem or the subcortical region or the cortex, right? Yes, muscle atrophy is typical of the lower motor neuron damage. Okay, so I think we have the clarity on the basics. We will start with the tone first, right? Tone is an important topic. Okay, so now what we need to know about tone. Tone is defined as a state of contraction of a resting muscle. Now what do I mean by resting muscle? A muscle which is not doing any voluntary movement. Now what is the voluntary movement, or what is the function of the biceps? To cause the flexion of the elbow, right? Now my biceps is not doing flexion of the elbow, right? My elbow is in a neutral state. Okay. At this point of time, when I feel the muscle, it is still out, it is not very flabby because it is in a partial state of contraction. So this is a resting muscle which is still in a state of contraction. This state of contraction is what we call as tone. Now how do I measure the tone? How do I assess it? So if my muscle is in a state of contraction, right, is it easy for me to stretch it? No, right? Because it is contracted, it is difficult for me to stretch it. So we can assess the state of contraction of a muscle by how easy it is for us to stretch. So when I am stretching, if it is offering resistance, that means the tone is higher. If it is not offering much resistance, that means the tone is lower. So tone is assessed by checking resistance offered to passive stretch of a muscle. Okay. Now what can happen with the tone? As long as there is no pathology, tone will be normal. But in a pathological condition, tone may be either increased or decreased, right? When it is increased, we call it as hypertonia. But hypertonia is of two types. I think we have already learned that in upper motor neuron damage, tone will be increased, and I mentioned that we call that as spasticity. But when we were talking about the motor system, I also told you there is one more system which is concerned with the voluntary movement, which is extrapyramidal system. So damage to extrapyramidal system also increases the tone, but that tone, increased tone, is what we call as rigidity. So we need to understand the difference between spasticity and rigidity. So when we are assessing the tone, we are basically passively stretching a muscle. So when we are passively stretching a muscle, we will see whether the resistance offered is same throughout the range of stretch, or whether it is initially more, and if I continue to stretch, the resistance disappears. Okay. So if it is same throughout the range of movement, right, from here to here, it is offering me the same resistance to stretch, then it is called as rigidity. Same level of resistance throughout the range of stretch of a muscle is called as rigidity. Rigidity indicates that we have the lesion affecting the extrapyramidal system. It indicates that there is a lesion involving the extrapyramidal system. Can anybody give me an example of a disorder affecting the extrapyramidal system where we can see rigidity? Now what is spasticity? Spasticity is a condition where there is increased tone, but when we are examining, right, initially there is intense resistance to the stretch, but then on persisted stretch the resistance disappears. So after that you will not experience much of a resistance. Initially too much of resistance, and after that the resistance disappears. This is what we call as spasticity. Spasticity indicates lesion affecting the pyramidal tract. And in pyramidal tract, what neurons we get? We get the upper motor neurons. That is why hypertonia that we see in upper motor neuron damage is also called as spasticity. There is another term used for describing spasticity. The spasticity is also called as clasp knife rigidity. Clasp knife rigidity. This is a clasp knife. In Hindi it is called as adkita. Some of you may be familiar with it. Basically used for like cutting the areca nut. If you handle this knife, you probably know that it gives too much resistance initially, but on persistent movement, suddenly it clasps or closes. Same kind of experience we are getting here, right? Initially too tight, and then suddenly the resistance disappears. That's why spasticity is also known as clasp knife rigidity. Spasticity is also known as clasp knife rigidity. Also known as clasp knife rigidity. This point has been repeatedly asked. Where do you get clasp knife rigidity? We get in patients with pyramidal tract lesion or upper motor neuron lesion. Where do we get rigidity? We get rigidity in extrapyramidal tract damage, right? Okay. Now the tone will be decreased whenever there is a damage to lower motor neuron. Decreased tone, we can call it as hypotonia or flaccidity. Hypotonia or flaccidity. Clear? Okay, so that is about the tone and the differentiation between upper and lower motor neuron. Okay. Deep tendon reflexes, let me address it. We have just learned about the reflex, right? Reflex has a sensory neuron and a lower motor neuron and an interneuron. The reflexes are happening at the spinal level. Deep tendon reflexes can either be exaggerated, in other words, brisk, exaggerated, or diminished. Right? The exaggerated deep tendon reflex indicates that there is damage to upper motor neuron, and diminished deep tendon reflexes indicates that there is damage to lower motor neuron. Damage to lower motor neuron. Okay. A classical example, I was talking to you about this extrapyramidal disorder, right? A classical example for the extrapyramidal disorder is our Parkinson's disease. Parkinson's disease. That is why patients with Parkinson's disease often have this rigidity, right? Okay. Now coming to the next important topic. I think we have addressed the upper motor neuron versus lower motor neuron differentiation. 3 key points. Let me summarize again. What are the 3 key points? The tone, deep tendon reflexes, and the plantar response, right? So if I have the upper motor neuron damage, what happens to tone? It is increased. If I have lower motor neuron, the tone is decreased. If I have upper motor neuron, deep tendon reflexes are exaggerated. If I have lower motor neuron lesion, deep tendon reflexes are diminished. If I have upper motor neuron lesion, the plantar response is going to be extensor, right? So I will write it as upgoing, extensor. If I have lower motor neuron lesion, the deep tendon reflexes are flexor or downgoing. So when you look at this, one thing becomes very clear, right? In upper motor neuron lesion, everything goes up. Everything goes up. Tone increases, deep tendon reflexes get exaggerated, plantar becomes extensor. When there is lower motor neuron lesion, everything goes low, right? The tone decreases, deep tendon reflexes decrease, and plantar goes down. That is flexor response. Clear? Okay. Then localization of lesions is an important topic, but this will take an entire day for me to address it from the scratch to the end. So what I will do is I will compile a table and give it to you in the notes. Those who have already studied the localization of lesion, if you go through the table, it should be more than enough for you to address the MCQs. Those who are new and connecting today, in the Reed Harrison series, we will be doing a separate session for the localization of lesions. You will get to know there. Okay. Now coming to the other important topics, one of the topic is going to be aphasia. I am expecting one question on aphasia this time, so we will start with that topic. Okay, so when it comes to aphasias, the usual kind of questions are going to be somewhat like this. You will have a clinical story where patients' speech issues are mentioned, and then they will ask you which type of aphasia it is. Okay, so I will start with a question and let me see if we can address this question. Okay, so here is a question about a patient with aphasia. Okay, what information we have from the question? We have a 30-year-old who presented with aphasia. Speech assessment revealed that he speaks with only few words and undue pauses in between. He was given appropriate answers to questions. He was able to repeat words but not able to name objects. Which type of aphasia it is? So how to approach such questions? How to approach such questions? Okay, so approach to aphasia is a pretty simple mathematical game. All we need to do is look for the information of 4 areas of assessment in the speech. What are those 4 areas? The first one is the fluency of the language. Second one is comprehension or understanding of the language. The third one is the naming, and fourth one is repetition. FCNR. Remember this, FCNR. Okay, what is fluency? Fluency refers to ability to make a transition from one word to next word without unnecessary pauses. So now I'm talking to you, I'm taking pauses where it is required. Right? So when we take pause, if it is required in a written language, we put commas and full stops. Right? That indicates that there's a pause required here. But if I take a pause unnecessarily, right, it whole distorts the listening experience. Right? If I say that I know that this is not good. So if I'm taking unnecessary pauses, that means the fluency is gone, right? So the best way to identify whether the fluency is intact or not is by looking at the description of the question, whether the patient is taking undue pauses, and second thing, if my fluency is not good. To give you an example, सोचो कि हाँ हम बात कर रहे हैं हिंदी में, अगर मुझे हिंदी ठीक से नहीं आती है, so if I have to communicate something but I don't know Hindi properly, what will I do? I will probably try to communicate with minimal possible words, right? I will not like to build up a sentence. Like if I'm hungry, I would say भूख instead of कि मुझे खाना दे दो, मुझे भूख लगी. I will not make a full sentence, right? So whenever a question says that patient is taking undue pauses or there is paucity of words, it means fluency is affected. So now get back to this question. Look at it and tell me what is happening with this patient's fluency. He speaks with only few words and he is taking undue pauses. Means what? The fluency is gone, right? Fluency is affected. Next thing is comprehension. What comprehension means? Ability to understand spoken language. So when I'm talking to you, you're able to understand, that means your comprehension is good. Now, how do I identify whether patient's comprehension is good in a given question? If the comprehension is intact, means the examiner might mention that okay, he's able to understand spoken language. But if he's not able to understand spoken language, examiner need not always tell you that the comprehension is gone. Instead, he will give you surrogate statements. One of the surrogate statement is inappropriate answer. Now, what do I mean by inappropriate answer? Okay, you ask a question. Like, let me say, I ask you a question. You will give me an answer. You will give me an appropriate answer only if you understood what question I am asking. If you don't understand what I am asking, you will give some answer which is not related to what I asked, right? So whenever the patient is giving you inappropriate answer, one possibility is that he has not understood the language or understood what you asked him. Second, when I am giving a response to something which I have not understood, obviously I will have a jumbled up approach. Means I will not properly construct a sentence, my grammar will be gone, right? So I will just throw different words at you. So that is what we call as word salad. So in any question where you see this description as word salad, you know that comprehension of this patient is gone. Okay. The third thing is they use another term called as neologism, which refers to coining new words. So in the question's description, they mention that patient is throwing out new words which do not exist in the English literature or English dictionary or like any language that patient is talking about. That means it is neologism. Again, it points towards impaired comprehension. Another word that they can use is jargon. Jargon refers to like a complex speech. Okay. So I would say that for me, Shashi Tharoor sir's language is a jargon because it is full of complex words. He has a normal, higher level of understanding of the language. That is why he throws complex words. But if your day-to-day regular patients are throwing some complex words, maybe they are doing that because their comprehension is gone and they are bringing in new words. And because of that, the speech now starts appearing full of jargon. So if you see these words, inappropriate answer, word salad, neologism or jargon, it means the comprehension is affected. Comprehension is gone. Now look at this question and tell me what is happening with this patient's comprehension. He was giving appropriate answers to questions. That means comprehension is intact. He will give appropriate answer only when he has understood the question. Clear. Now the remaining two things are pretty simple, right? You give an object to the patient and ask him to name it. Like I give this to you and ask you what is it. You will say, sir, this is a pen or a pencil, which is fine, right? I give you a bottle of water and you would say, sir, this is a bottle of water. Fair. So ability to name is the third assessment. The fourth one is repetition, right? I will tell you to repeat words after me. If you're able to repeat, that means repetition is fine. So here the question mentioned that the patient was able to repeat words, means repetition is intact, but not able to name the objects. He is not able to name the objects. So which type of aphasia it is? So once we do this work of deciphering the information about these 4 areas of speech assessment, rest of the thing is pretty simple. It is a mathematical game. So what we need to do is, once we have understood the speech assessment, there are different types of aphasias, and out of these 4 areas of our speech assessment, we will only look into how many of the domains of these 4 are affected. If all the 4 are affected, means fluency is gone, comprehension is gone, naming is gone, repetition is gone, we call it as global aphasia. Global means we know, right? Everything, all gone. That is global aphasia. Neither patient understands nor speaks properly. Then we have 2 most common aphasias, which is Broca's aphasia and Wernicke's aphasia. In Broca's or Wernicke's aphasia, right, 3 out of the 4 domains are affected. Only 1 domain is unaffected. We have fluency, comprehension, naming and repetition. Out of this, 3 are affected and 1 preserved. Such aphasias include Broca's and Wernicke's. Okay. So in Broca's, it is usually the comprehension which is preserved. So means what? In Broca's, comprehension is preserved means you talk to them, they understand because they are able to comprehend. You ask them a question like, what's your native place? They understood you asked what is your native place. But their fluency is gone. So when they try to respond, they will respond with a broken language, with minimal words, unnecessary pauses or unnecessary full stops. They will struggle to produce the words. They will say like, my native is in Mysore district of Karnataka, right? But instead of saying this, that I am from a small village in Mysore district of Karnataka, they would say Karnataka, right? Minimal words, paucity of words, unnecessary pauses. Right? And if you ask them to name or repeat, they will not be able to name or repeat. That is our Broca's aphasia, right? What to remember? Just remember BC. BC. For North Indians, it is slang, you know what that means. So if you remember BC, right? In Broca's, in B, C is preserved. Comprehension is preserved. Okay. Then in Wernicke's, it is flipped. In the sense, naming and repetition, as you see, both are constantly affected in most of the speech disorders. So one of the remaining 2 should be preserved. So in Wernicke's, it is the fluency which is preserved and comprehension is gone. So when the fluency is preserved and comprehension is gone, what will be the story? The patient will be able to speak continuously without unnecessary pauses, right? He will be able to make a sentence with no pauses, but he will not understand what you are asking him. So when he is not able to understand what you are asking him, what he will do? He will give you inappropriate answers. He will bring in new words that do not exist. That is what we call as neologism, right? He will fail to construct a proper grammar. So you will have all words just thrown at you like a salad. So word salad, jargon, right? That is what neologism we will say. Patient has got Wernicke's encephalopathy. Now looking at this question, what do you think? The patient has got any of these 3? Global means all 4 affected. Is it global? No. Right. The second, Wernicke's or Broca's. In Broca's and Wernicke's, 3 out of 4 are affected. So in Broca's, the fluency is affected, comprehension is intact, naming and repetition are affected. And in Wernicke's, fluency is intact, comprehension is gone, naming and repetition is gone. So this is neither Broca's nor Wernicke's, right, nor global. Those 3 are out. So from this question, I can confidently rule out Broca's and Wernicke's. Now what am I left with? Among the options, we have transcortical motor aphasia and conduction aphasia, right? So we will look at the further types of aphasias where among the available 4 domains, only 2 are affected. One of them is conduction aphasia. Then the other 2 are called as transcortical motor and transcortical sensory aphasias. Okay. Now what is this conduction aphasia? Conduction aphasia is a condition where 2 domains are affected and those affected domains are repetition and naming. It's very difficult to diagnose aphasia because these patients' fluency and comprehension is fine, right? You ask them a question, they understand the question. They understood what you asked, right? And they will be able to give you an appropriate answer comfortably without unnecessary pauses, right? They will frame a proper sentence because their fluency is also fine. Only when I ask them to repeat after me or give them an object and name it, they will struggle. That is where I get to know that, okay, this patient has got conduction aphasia, right? Then we have 2 more conditions where out of the 4, only 2 domains are affected. That includes transcortical motor and transcortical sensory. The way to remember transcortical motor and transcortical sensory is just think of Broca's. Transcortical motor, think of it as Broca's, and transcortical sensory, think of it as Wernicke's. The only difference is, see, Wernicke's, what happens? Fluency is intact, comprehension is gone, right? Repetition is gone and naming is gone. The only difference here, see, in the transcortical sensory, I told you think of it as Wernicke's. In Wernicke's, fluency is intact, comprehension gone, naming gone, repetition gone. The only difference here is in the transcortical sensory versus Wernicke's, intact repetition, repetition unaffected. Transcortical motor, think of it as Broca's. So in Broca's, what happens? Fluency is gone, comprehension is intact, repetition is gone, naming is gone. Again, what is the difference between the Broca's and transcortical motor? It is the intact repetition. So Broca's aphasia with intact repetition and Wernicke's aphasia with intact repetition is what we call as transcortical motor and transcortical sensory aphasias respectively. Clear? So now get back to this question. From this question we have the clarity that only two domains are affected, which is fluency and naming. So 2 out of 4 domains affected means either it has to be conduction aphasia, transcortical motor or transcortical sensory. So what do you think is this? What do you think is this? So in conduction, I told you it is one of the difficult to diagnose aphasia because only naming and repetition are affected. Fluency is fine, comprehension is fine. जो भी सवाल पूछो पेशेंट को समझ में आएगा, आंसर भी अप्रोप्रिएट देगा without unnecessary pauses or breaks. Only naming and repetition will be affected, so it is very difficult to diagnose clinical practice में. So this is definitely not conduction aphasia. So I can comfortably rule that out here. It is not conduction aphasia either. So what am I left with? Transcortical aphasias, motor and sensory. What did I say? Think of transcortical motor as Broca's aphasia with intact repetition, and think of transcortical sensory as Wernicke's aphasia with intact repetition. तो यहाँ पे repetition, yes, it is intact, and because fluency is affected and comprehension is intact, it makes it more like Broca's, right? What is the story of Broca's? Fluency gone, comprehension intact, naming gone, repetition gone. Now take that away, bring back the repetition, and that becomes transcortical motor. So this patient is suffering from transcortical motor aphasia, and that becomes our answer. So this helps you to get 1 mark on aphasia. It's a very, very important topic. If you're thinking that is it worth spending 20 minutes on aphasias, it is definitely worth, because from the neurology, most of the questions are grounded in the basics like tone, deep tendon reflexes and tremors. Those are the most commonly tested topics. When it gets to the complex neurology, it is mostly the aphasias from which regularly questions are being asked. Okay. Then they will ask you one more level of question. They will tell you the story. You have to recognize which aphasia it is, and then they will ask you where is the site of lesion. Right? Where is the site of lesion? So for that, we will just take a quick look at how the speech system functions. Okay. So for the speech, for us to understand the speech, we have a Wernicke's area. This Wernicke's area is there in the temporal lobe, right? Posterior part of the temporal lobe. We have the Wernicke's area, and then we have the Broca's area in the frontal lobe, right? Broca's area is in the frontal lobe, Wernicke's area is in the temporal lobe, and the connecting the two is our arcuate fasciculus or arcuate fasciculus. The damage to Broca's area what causes the Broca's aphasia, right? And the damage to the Wernicke's area causes the Wernicke's aphasia, and the damage to arcuate fasciculus causes the conduction aphasia. Damage to arcuate fasciculus causes conduction aphasia. Okay. Recent times they have asked questions related to blood supply to these areas. So let me make that also clear. Whole of the speech apparatus primarily gets its blood supply from the middle cerebral artery. Okay. Now middle cerebral artery runs in this sylvian groove. Okay. And then it splits into two, a superior division and an inferior division. So this MCA split into superior and inferior division. It is the inferior division which is giving the blood supplies to the Wernicke's area. So if I block this inferior division of MCA, I develop Wernicke's aphasia. Clear? Generally, whenever you see patients with Wernicke's aphasia, they only have aphasia. They don't have hemiplegia, only aphasia. But the occlusion of this superior division of the middle cerebral artery causes Broca's aphasia because blood supply to Broca's is cut. The superior division is also giving the blood supply to this motor area. We were talking about this pyramidal tract, right? Starting with the motor area. So this motor area is getting the blood supply from the superior division of MCA. So if I block this blood vessel, Broca's area is not getting blood, motor area is also not getting blood. So because motor area is not getting blood, I will have hemiplegia on the opposite side, and Broca's area not getting the blood will lead to Broca's aphasia, right? So in simple words, inferior division MCA only leads to the Wernicke's aphasia. Blockage of the superior division of MCA leads to Broca's aphasia plus the hemiplegia. So that kind of questions they often ask, right? Superior division MCA occlusion leads to Broca's aphasia and contralateral hemiplegia. Inferior division of MCA occlusion lead to Wernicke's aphasia. But MCA occlusion prior to bifurcation means here, if I block it here, neither superior division is going to get blood supply nor the inferior. So I will have Wernicke's plus Broca's aphasia. That is what we call as global aphasia. Fluency, comprehension, naming, repetition, all gone. Global aphasia plus contralateral hemiplegia. Clear? Okay. So that addresses our important topic, that is aphasia. Now there is one more topic, that is Gerstmann syndrome. Gerstmann syndrome. This has been repeatedly tested, mainly because the syndrome is dramatic and they can easily confuse the student around this Gerstmann syndrome. Okay. So what is this Gerstmann syndrome? Can anybody tell me the components of the Gerstmann syndrome? The most common transient aphasia is anomic aphasia. Okay, few more points I probably did not address. There is also an aphasia where only one of the 4 domains affected, means only naming is affected, everything else is fine, means comprehension is fine, right? Go and ask the patient, where do you come from? He will say, I come from Madurai, comfortably, right? Comprehension is good, appropriate answer, unnecessary pauses are not there because fluency is good, right? Ask him to repeat after you. Okay, so you're from Madurai, so then say Madurai Meenakshi Ammal temple. He will say Madurai Meenakshi Ammal temple. He will say. Repetition is intact. Only naming is gone, right? Give him a pen and ask him to name what is it, right? Give him this and ask him to name. He would say it's used for writing, but he will not be able to name that this is called as pen or pencil. That is what we call as anomic aphasia, means inability to name. Anomic aphasia. Anomic aphasia is the most common aphasia following head injury. That is why whenever someone suffers a massive road traffic accident and sustains head injury, when they are brought to the hospital or ICU, they have difficulty to name people, name objects. Okay, and it is also the most common aphasia whenever there is metabolic damage to brain. We call it as metabolic encephalopathy, like when urea is high, uremic encephalopathy. Ammonia is high in liver disorders, what we call as hepatic encephalopathy. We can have anomic aphasia, and it is also the most common transient aphasia, means this hepatic encephalopathy, once the ammonia comes down, the patient will regain his ability to name objects. Head injury patients, after a few days, they will regain their ability to name the object. So that is why it is the most common transient aphasia. Broca's aphasia because of stroke, very difficult to recover from it. Wernicke's aphasia because of stroke, very difficult to recover from it. Okay, yes. So Gerstmann syndrome refers to a condition where patients have a complex set of symptoms, right? But for us to understand that, we need to get into the parietal lobe. So when we talk about the parietal lobe of the brain, the parietal lobe has, right, we have 2 parietal lobes, right and left. One of them will be acting as a dominant parietal lobe, the other one will be non-dominant. Dominant and non-dominant. So both of them have their designated functions. So when you look at the dominant parietal lobe, there are some important areas. So parietal lobe, as you know, is behind your central sulcus and slightly superior to your parieto-occipital sulcus. So this is parieto-occipital sulcus. Here I have the occipital lobe. Right? This is the frontal lobe anterior to the central sulcus. So posterior to central sulcus, superior to the parieto-occipital sulcus is where we have the parietal lobe. On the dominant parietal lobe, one of the important area that is active is going to be your sensory cortex, which is concerned with the perception of higher cortical sensations like aphasia, stereognosis and all. And then we have an area called as angular gyrus. Angular gyrus. And what are the functions of this area? This area helps you to learn. It gives you the ability to learn. Learning is an important function of this area. Then the second function of this area is it helps you to writing. Third, it helps you to distinguish between the left and right. Left and right. Discrimination is also a function of this area. Okay. Then this ability to learn is what we call as lexis. Okay. Ability to write is what we call as graphia. Okay. Then left right discrimination. It helps you to identify your fingers. Finger identification. Finger identification. So when there is a lesion or damage to this angular gyrus, right, we will lose our ability to learn. So when we lose our ability to learn, we call it as alexia. Alexia. Then we lose our ability to write. Means we know the language, right? We can recognize the letters, but we can't write. We call that condition as agraphia, as someone had already pointed. Okay. Then we lose our ability to differentiate between कौन सा left side है या कौन सा right side है. So we call that as left right confusion. Confusion between the left and right. And the fourth one, we fail to identify our fingers, right? Ask the patient to show the ring finger, the patient will show the middle finger. That's what they get confused between which finger is which. So we call it as finger agnosia. Finger agnosia. Agnosia refers to lack of knowledge. Gnosis is the parent word from which the word knowledge has come. When you say agnosia, we have lost our ability or the knowledge. So these are the key symptoms of the Gerstmann syndrome, right? Alexia, agraphia, left-right confusion and finger agnosia. Okay. So what question they will ask you is the lesion of which of the following parts causes Gerstmann syndrome? You know, it is angular gyrus, but in the question they will not mention angular gyrus. They will mention parietal lobe, but they will mention two parietal lobes, the dominant parietal lobe and the non-dominant parietal lobe. Right, so please remember, angular gyrus, this area is active on the dominant parietal lobe. So when there is a lesion of the dominant parietal lobe, we develop the Gerstmann syndrome. It is not active on the non-dominant parietal lobe. So what are the functions of dominant parietal lobe? The sensory cortex is there. So you have what is called as cortical sensations, which is the function of dominant parietal lobe, which includes stereognosis, right, graphesthesia, then 2-point discrimination. These are all cortical sensations. Tactile localization. These are all cortical sensations, which is function of the dominant parietal lobe. Apart from that, angular gyrus, which is helping you to learn, write, right, and then differentiate between left and right and identify your fingers. So all of that will be lost. That is what we collectively call as, when all of these are affected, we call it as Gerstmann syndrome. Gerstmann syndrome. Okay. Then we have this non-dominant parietal lobe, which also has functions, right? What are the functions? Again, why am I talking about it? Because in one of the FMGE, there was an image-based question. There was a question where a patient was asked to draw a clock. So they give the image of that clock drawing from the patient, and then they will ask you what is the diagnosis, right? So what are the functions of non-dominant parietal lobe? It has two important functions. The first function is it helps you to construct the shapes. Means in simple words, we call it as construction skills. When I say construction skills, I am not referring to skills required for construction of giant mega architectures. Basic construction skills, right? When you hand over some 3 or 4 cubes to an individual and ask him to arrange it like a tower or arrange it like a rectangle, he will be able to arrange it, right? That is what we call as construction skills. Construction skills. That is a function of your non-dominant parietal lobe. And the second function, it gives you the awareness of body parts. Means we all know that, okay, I have right hand, left hand, Right now, though I'm not thinking that okay, I have legs and all, subconsciously my body is aware that okay, I have two legs. It won't happen that I will finish this class and get up and go to my home leaving behind my legs, because subconsciously I'm aware of it. So I will always, in simple words, I would say my subconscious mind knows where exactly my body parts are positioned right now, right? Whether they are on the chair, whether they are on the floor, my subconscious mind knows. That all comes from our non-dominant parietal lobe. So we call it as awareness of body parts. Awareness of body parts. Okay. Now, if there is a lesion of this non-dominant parietal lobe, if there is a lesion of non-dominant parietal lobe, what it will lead to? I will lose my construction skills. Means you give me just 3 cubes and ask me to arrange it like a tower, I will not be able to do it if there is a damage to non-dominant parietal lobe. So we call that condition as constructional apraxia. Constructional apraxia. So those who don't know, let me tell you what apraxia refers to. Right? Praxis is a word, parent word from which apraxia comes. Praxis. What praxis means? Praxis refers to our ability to carry out learned skills. See, just to give you an example, I can keep talking to you while driving. Right? Driving is a skill that I have learned. Right? All the movements required for driving I have learned. Now my subconscious brain can still execute the act of driving when I'm talking to you. So my attention may be partially towards you, but still I will be able to drive. So that is the praxis, ability to carry out a learned skill. If I've learned to do some complex physical movements, right, some dance steps, as long as I'm able to carry them out, it is praxis. But once I lose a skill which I had learned, see, now I really don't know dancing, so I don't have that skill. So it is not like, okay, I will lose that. If I'm not able to dance now, it's because I've not acquired the dancing skills. That is a different story. But if I had acquired dancing skills, but now I'm unable to execute those movements, that means I have developed apraxia. So apraxia refers to loss of learned skills. The skills which you had acquired, now you are losing them again. We call it as apraxia. So you could construct the shapes right from your childhood, right? From 3 year or 4 year, you start building the towers. Now you have lost that. So we call it as constructional apraxia. Second thing, you lose the awareness of body parts. So when we lose the awareness of body parts, we call it as anosognosia. Anosognosia means agnosia, as we just understood, means you don't know or lack of knowledge, and anos here basically refers to anatomy. So you are losing the awareness of your own anatomy or body parts. We call it as anosognosia. Okay. It is easy to identify constructional apraxia. All I have to do is give some cubes or some objects to the patient and ask him to make a shape or construction out of it, right? Build a tower or arrange them like a rectangle. He will fail to do it, then I know he has got constructional apraxia. But how to identify anosognosia? Means he does not know how, like, whether he is aware of his body parts or not. How would I get to know? See, the basic rule is, if you're aware of your body parts, you'd kind of take care of them. Like, I know I have hair, so I will comb, right? I know that I have a face, so I will probably wash, right? I know I have teeth, so I will brush. But if I'm not aware of some body parts, I will not take care of them because they don't exist in my world. That is what we call as neglect, right? So for these patients, they don't only neglect the body parts of the affected side, they will also neglect the space on that side. So we call it as hemispatial neglect. Hemispatial neglect. Hemispatial neglect. So whenever you have a patient with hemispatial neglect and constructional apraxia, it indicates damage to non-dominant parietal lobe. So in the exam, you will get two kinds of questions. The one image-based question directly talking to you about this anosognosia, or the other one will be, just give me a second, I will show you an image. That's an important image I want you to know. Then, so here you have that image. This is what we call as hemispatial neglect. So this patient is not aware of his left side of the body, so he is not taking care of it, right? So he has ignored it. That is why all the beard, mustache, everything is grown. So if I see this patient, I clearly know that this patient has got a damage to the non-dominant parietal lobe. But if there is a caretaker, then they will shave him, right? They will make him neat and then bring him to the hospital. So in that case, there is no clue that this patient has got hemispatial neglect. But if I'm still suspecting the possibility, then I will ask him to draw a clock. I will ask him to draw a clock. Now there will be two types of clock drawing. One, in the exam they will give an image like this, and in another image they will give like this. So please remember, if the patient has got hemispatial neglect, right, hemispatial neglect, then all the clock numbers will be crowded in one side of the clock. That is the most important thing. Only one side of the clock. Why? Because he is neglecting one side of the space, right? Okay, so if I am sitting here, this half of the space I am neglecting, but the other eye will still see all the 12 numbers in the clock. So when I want to jot it down on a piece of paper in a shape of clock, right, I am seeing all the 12 numbers. See, close your eyes and look at a clock, you will see all the 12 numbers, right? But I am not aware of the space on this side. So when you ask me to construct a clock, what I will do is, I saw 12 digits, I will put all the 12 digits in one side of the clock. That is how the hemispatial neglect looks like. If they give you this image, this is not hemispatial neglect, right? That means the patient is not seeing half of the clock at all. Maybe some ophthalmological problem. But when you see all the numbers crowded in one side of the clock, that is what we call as hemispatial neglect. And this is the question that they have asked multiple times. They have given the image. In one question, they had given 4 images of clock drawn by the patients, and then they had asked you to identify which one is hemispatial neglect. The one where all the 12 numbers are crowded in one side of the clock. Clear? Okay. Now our another important topic is going to be the movement disorders. Movement disorders. In the movement disorders, what they will ask you is the classification related questions, and then there are 2 templates of questions. One is, there are some movement disorders where they will ask you where is the lesion, means which part of the brain should be damaged to get this movement disorder. And the second set of questions are primarily focused on one of the movement disorder, which is tremor. So we will focus on tremor and other movement disorders. Okay. Now if I have to talk about movement disorders, these are conditions where there are abnormal movements happening. Broadly, abnormal movements are classified into hyperkinetic movement disorders. Hyper means increase. So those are the conditions where the movements are increased, and hypokinetic movement disorders where the movements are decreased. Hypokinetic movement disorder, the classical examples we should think of is Parkinson's disease. See, whenever we talk about Parkinson's disease, we talk about what is called as bradykinesia, right? Bradykinesia in the Parkinson's disease is the condition where there is decreased movement, right? The patient has got only slow movements. It's a hypokinetic movement disorder. Hyperkinetic means there are increased movements. These hyperkinetic movement disorders are further divided into rhythmic movement disorders and non-rhythmic movement disorders. Rhythmic and non-rhythmic. I'll tell you what does that mean. So when I say rhythmic, means a movement is repeating in same amplitude and same frequency. To give you an example, if a person keeps doing this, right, is it rhythmic or not? Is just continuing to do this, right? It's like, to show you, goes down this much, comes up this much, right? It is following the same pattern. That is what we call as a rhythmic movement disorder. Okay, but if the patient keeps doing this, it's not following the same pattern, right? It is going randomly here and there. It is not the same movement that is repeating again and again. Such movements are called as non-rhythmic hyperkinetic movement disorders. So rhythmic movement disorders, there are 2 of them. One of them is called as tremors. The other one is called as dystonia. Okay, tremors and dystonia are rhythmic movement disorders. Dystonia, classical example is torticollis. Torticollis is where neck is turned one side, right? Why is it turned one side? Because this muscle right? One of the muscle is constantly contracted, that is dystonia, right? Tremors, I think all of us are familiar with. So tremors, same movement keep repeating again and again. And in non-rhythmic movement disorders, it is not the same movement which keeps repeating. Okay, so we will understand some points about tremors and some points about non-rhythmic movement disorders. I'll keep it succinct so that it is primarily useful for the exam going students. Okay, so tremors are further classified into rest tremors, intention tremors. Please remember, intention tremors are also called as action tremors and postural tremors. Postural tremors. Okay. What are rest tremors? Those are the tremors which occur when an affected limb is at rest. Affected limb is at rest. Means I'm sitting here, my hands are continuously doing the same movement. That is a rest tremor. A classical example for rest tremor is the tremor that we see in Parkinson's disease. Parkinson's tremor is a classical example for rest tremor. Okay. Then what is intention or action tremor? Intention or action tremors are those tremors which appear when you make an action or a movement of the affected limb. Means, okay, I'm sitting here at rest, my hands are not having any tremor, but I try to move, then the tremor comes in, right? So when I have an intentional movement or when I make an action, the tremor comes in. At rest, it is not there. Such tremors are called as intention tremor or action tremor. A classical example for this tremor is going to be our cerebellar dysfunction. Cerebellar dysfunction. So whenever cerebellum is not able to work properly, we can develop intention tremor or action tremor. Okay. Then postural tremors are those tremors which appear only when limb is held in a particular posture. They are not there at rest. They are not there during the regular movement. You have to put the limb in a particular posture. Only then the tremor comes. Such tremors are called as postural tremors. The classical example for postural tremors are, you might have seen in last FMGE or the previous FMGE, there was a question where they had given an image of a hand, right? And then they had indicated that this hand is moving in a fixed pattern. They had given 3 images, right? Hand position here, here and here. And then I think they had asked in which condition it is seen. So that tremor is what we call as asterixis or flapping tremor. Flapping tremor or asterixis. Flapping tremor or asterixis, that is one example which is seen in patients with hepatic encephalopathy, then patients with uremic encephalopathy, and then in patients with hypercapnia or increased carbon dioxide in the blood. These are the 3 conditions where you can see this asterixis or flapping tremor. Please remember this. This is a very potential and important MCQ point. Where do you see asterixis or flapping tremors? Okay. The second example, as Sachin Rajput mentioned, there is something called as wing beating tremor. Wing beating tremor. I think just a couple of days back I had shared a video of a child with a wing beating tremor. Wing beating tremor refers to a postural tremor where the tremor appears only when you ask the patient to bring his hands closer or approximate at the eye level. So when he tries to do this, the tremor appears. What kind of movement we will see? Mainly the movement happens at the shoulder joint. So patient starts moving his shoulder joints. So this tremor is what we call as wing beating tremor, which is seen in patients with Wilson's disease. In patients with Wilson's disease. Okay. Now there is one tremor which kind of creates controversy. In fact, 2. One of them is the alcohol withdrawal tremor. And the second one is essential tremor. Okay. Now, you might have seen some patients in wards who were chronically alcohol dependent, but once they get hospitalized, right, they are not getting alcohol anymore. After 2 or 3 days, they start developing tremor. Now, what should I count this tremor as? Rest tremor or postural tremor? That is where the controversy happens. And same applies to essential tremor. In fact, I am a patient with essential tremor. Okay, so I have minor tremors, which may not be visible to you easily, but yes, I have essential tremors. Now, should I count this as essential rest tremor or postural tremor? Both alcohol withdrawal tremors and essential tremors are rest as well as postural tremor. In the sense, when you have the essential tremors and alcohol withdrawal tremors in the very mild or early stages, they may not be easily visible at rest, but when I take a posture, right, I hold the limb in front of you like this, then the tremor becomes visible. Some of you may be able to see it right now. So posture aggravates it. But as the condition progresses and becomes more severe, it is there at rest itself, right? A patient with alcohol withdrawal, today when you ask him to raise his hands, you hold the limb against the gravity, the tremor appears. Tomorrow or day after tomorrow, at rest only, he will be shaking. Same applies to essential tremor. Right now, you will be able to see only when I hold my limb against the gravity. 10 to 15 years down the line, it may be visible at rest easily. So for exam, what should I count it as? Rest or postural? What appears to me by tracking the NBE and its results and outcomes, I would say NBE counts these as the postural tremors, and it is safer for us to take them as postural tremors for the sake of exam. But I've already told you, in milder or early stages, it is clearly only postural. As it becomes more severe, it becomes rest, right? So for the sake of exam, we will count them as postural tremors. Postural tremors. Okay, so that completes our quick discussion on the movement disorders, that is tremors. But there are also some non-rhythmic movement disorders. I want you to remember 3 of them. I will give you clues to identify these non-rhythmic movement disorders and the site of lesion. Non-rhythmic movement disorders include chorea, athetosis, and balismus. All the in simple words, the movement disorders are because of extrapyramidal tract damage. Whenever I have a movement disorder, it means extrapyramidal tract is affected. Now, extrapyramidal tract or the extrapyramidal system has multiple nuclei, like you have basal ganglia, caudate nucleus, right, putamen. So multiple nuclei are there. So what they will ask you is, they will give you a story. Like this patient has this kind of abnormal movements. So then you have to make a mental diagnosis whether this is chorea, whether this is athetosis, or whether this is balismus. And then they will ask you the lesion of which part of the brain or the nervous system produces this condition. So if it is balismus, that is what we have understood from the question, then we should be able to tell the site of lesion is going to be this to cause balismus. So what clues? Okay, chorea is a abnormal movement because of extrapyramidal lesion, where the movement does not have a fixed pattern. If it has a fixed pattern, then it will become a rhythmic movement disorder, then it will become a tremor or dystonia, right? If I keep moving my hands like this, it is a fixed pattern, then it will become a tremor, right? If I keep doing my hands like this, it's a fixed pattern, then it will become a tremor, right? I forgot to mention the rest tremor that we see in Parkinson's disease patient, right? It is also called as pill rolling tremor. Pill rolling tremor, because when you look at the patient's hands, right, it looks like they are trying to roll a pill between their thumb and rest of the fingers. The movement is like this. That's why it is called as pill rolling tremor. So whenever we describe tremor, we try to describe by linking it to some day-to-day activity, right? Pill rolling, it looks like pill rolling, so we call it as pill rolling tremor. Looks like the beating of the wings, so we call it as wing beating tremor in Wilson's disease. This looks like flapping, so that's why it's called as flapping tremor. So we try to relate it to something that we see in day-to-day life, so that while describing it becomes easier, and for someone to understand it becomes easier. But in non-rhythmic movement disorders, the movements are not following a set pattern. So I can't say that this looks like the beating of the bird's wing, or this looks like the flapping. It is difficult because the movement is changing. It is not one movement that is constantly happening. But we will still try to describe them closer to some day-to-day events that we encounter. So chorea is an abnormal movement disorder where increased movements are happening, Those movements are dance-like. They're usually described as dance-like. Means when you see a patient with chorea, right, they will be doing something like this. So this is not a very random movement, but this doesn't have a set pattern. It's not like only one movement or one fixed set of movement is happening. Random movements, but it kind of looks like someone has choreographed these movements. Someone has choreographed this movement. That's why we have used the term chorea. The term chorea comes from choreography. So movements are random, but it looks like maybe someone has choreographed it. So we call it as dance-like. For exam going students, as of now, just remember the word dance-like. If they say that there is a patient with a movement disorder where movements are dance-like, it is talking about chorea. And then if there is a patient with abnormal movements and they mention that the movements are either they use the word slow writhing movements or they say snake-like movements. Slow writhing movements or snake-like movements. See, the chorea, when someone choreographs, right, the dance steps, now we know that they're all fast. So the chorea movements are rapid. In patients with athetosis, there are random movements happening which are very slow. Right? These patients with athetosis will be doing like this. Very slow movements. That's why it's called as writhing movements. Writhing is like when you get up and do this. That's writhing movements. Slow writhing movements or snake-like movements. That means you have athetosis. And whenever examiner says that patient has got violent flinging movements, he is pointing towards balismus. In fact, the word balismus comes from ballet, right? If you've seen ballad or ballet, where the hero holds the girl and swings her in the air, right? Like you hold her hand, move this side, move that side. That's ballet. So that kind of violent movements, right? Violent, brisk movement. So whenever they say the patient has got violent flinging movements, the question is pointing towards balismus. Now what you need to know is identify which movement disorder the question is talking about, and please look for these keywords. So if it is dance-like, choreography, chorea, right? If it is snake-like or slow writhing movements, athetosis. And if it is violent, the moment you say violent, think of ballet or balismus. Then what is the final point in the question? They will ask you lesion of which part produces these symptoms, right? So that is pretty easy to remember. Okay, so chorea is due to lesion in caudate nucleus. It is due to lesion in caudate nucleus of the extrapyramidal system. Caudate nucleus. Pretty easy to remember because it is C for C, right? So as long as you remember C for chorea, caudate nucleus. Okay. Athetosis is due to lesion in putamen. The putamen lesion produces the athetosis, and the balismus is due to lesion in subthalamic nucleus. It is due to lesion in subthalamic nucleus. Subthalamic nucleus. Okay, how now it is easy for me to remember chorea for caudate, C for C, but how to remember putamen for athetosis and subthalamic nucleus for balismus? This becomes confusing in the examination hall, right? In fact, in one of the NEET PG question, they had given these three lesions and they had asked you to match the outcome, right? Chorea, we could easily match with caudate nucleus, but what about athetosis and balismus? I will make that also a bit easier for us to remember now. Okay, let us pick the word violent, right? And think of a cricketer, batsman, who is really violent to the ball, right? On the ball, he's having violent movements to the ball. Who comes to your mind? Okay, pick an Indian only. Let us be like Desh Premis. For me, obviously, it is going to be Dhoni, right? Dhoni comes first to my mind whenever I have to think of a violent batsman. Dhoni. And how do we address him as? Right, he is famously called as Tala, right? So if you think of violent, that is ballet, and Dhoni comes to your mind, that is the Tala or the thalamic nucleus, right? So that way you can remember that the lesion of subthalamic Tala, Dhoni, right, leads to violent batting, that is balismus, right? So that helps you to address this chorea, athetosis and balismus. So what we have addressed now are the most important topics: the tone, reflexes, right? Certain syndromes, aphasias, and movement disorders. Out of these, I am expecting 2 to 3 questions. Okay. Another 1 or 2 questions might come from GB syndrome, myasthenia gravis, and stroke. Those 3, I will give you a short summary in one page summary of each in the notes. Just take a quick look. If you have already attended offline sessions or you have watched videos online, those summaries should be more than enough. Along with that, I will be sharing 10 questions in the PDF notes, which according to me are the most important for this time's exam. Go through them. That hopefully helps you to push your preparation towards a little better dealing of the neurology. I will be signing off for this session. The next session is probably on cardiovascular system. In cardiovascular system, again we will pick up the 10 most important topics and we will quickly revise them, right? So that's it for today, guys. I'll see you tomorrow at 4 p.m. Thank you. Thank you. And apart from that, if you have any specific request, like, okay, this topic is difficult for me or I'm not able to remember, let me know through Telegram or Instagram. Individually, like whoever needs those topic, we will address them. Though they may not be equally important for everybody else, but if you are stuck with a topic you're not able to understand, I won't mind helping it. Okay. Headache, yes, headache is an important topic. So we will just spend 5 minutes to quickly dissect headache. So whenever we have a question on headache, there are 2 or 3 type of questions that will be asked on headache. The first one is diagnose which type of headache it is, whether it is migraine, tension type, or cluster headache, or whether it is SUNT or SUNA. The second questions are mainly from pharmacology. What is the drug of choice for acute treatment? What is the drug of choice for preventive treatment, right? So whenever you see a question of headache, all you need to do is look at the duration. The first thing you have to look at is the laterality, whether the headache is unilateral or bilateral, and then the duration of headache, how long an untreated episode of headache lasts. Apart from that, examiners will generally bestow some clues for the diagnosis. We have to pick up those clues. Okay. And then last thing is about drug of choice for acute treatment and for preventive treatment. That's all is important from the headache. So what are the differential diagnoses for the headaches we have? We have the primary headaches and the secondary headaches. When I say primary headache, under that we have tension type of headache, migraine, and we have a set of headaches called as trigeminal autonomic cephalgia. Our cluster headache, SUNT, SUNA, paroxysmal hemicrania all comes under this, right? And when it comes to secondary headache, these are the conditions where there is some other medical problem which has resulted in headache, right? So first thing, whenever we have a patient with headache, is we have to rule out secondary headache. How do we rule out? We rule out by looking at what we call as red flag signs. Red flag signs. What are the important red flag signs which indicate that the patient is not having a primary headache, he must be having a secondary headache? So important red flag signs are presence of fever, neck stiffness. Fever and neck stiffness indicates that patient may be having meningitis or other infections as a cause for headache. Then presence of projectile vomiting, then bradycardia, bradycardia and hypertension. What does this indicate? It indicates patient has got raised intracranial tension. So there must be a bleeding inside the brain, right? Maybe in the parenchyma, epidural space, subarachnoid space, or the subdural space. Yes, then presence of papilledema. Again, papilledema also indicates that patient has got raised intracranial tension. So these are all what we call as red flag signs. I think in the main notes I've given you the exhaustive list of red flag signs. These are the important ones that you need to look for. If any question mentions these, that means patient has got the secondary headache. So in that case, the next best step is to image the brain, either do a CT scan or MRI to identify why this patient is having these signs or symptoms. Okay. If red flag signs are not there, then there is no need for imaging in a patient with headache. We make a clinical diagnosis. So we have to learn how to differentiate between tension type, migraine and trigeminal autonomic cephalgias. So first thing we should look at is the laterality. So if you are convinced that the patient is a primary headache, right? So when we have a patient with headache, if there are no red flag signs, then we are mostly dealing with a case of primary headache. We are dealing with a case of primary headache, and if it is a case of primary headache, first thing we have to look at is the laterality, whether it is unilateral or bilateral. If it is unilateral, then it is most likely migraine or tax. Bilateral, whenever it says bilateral, the first thing that should come to your mind is it is going to be a tension type of headache. So laterality makes it pretty easy for us to identify. So if I have headache where I have ruled out the red flag signs, then first thing I will look at laterality. If it is bilateral, tension type comes to my mind. Now in tension type, there will be additional clues. As I've already told you, apart from laterality, duration and certain additional clues that the examiner gives, we should also look for that to confirm our own assumption of diagnosis. So in tension type of headache, apart from being bilateral, right, what additional points examiner will mention? He will mention that the duration of headache usually runs for several days. It is a chronic headache, usually runs for several days. Second thing he will mention is that the headache severity is going to be mild to moderate in terms of severity. It's not a very severe headache. Okay, so that is why these patients will not come and tell you that mera sir fatne wala hai. The patient will come and tell that some kind of heaviness I am experiencing, and examiners have specific ways of describing it. And what is that? They will mention that patient is describing a band-like sensation. So usually sometimes they give an image also of a person, right? They will give an image, and then they will show that this is the area where the patient is experiencing the headache. A band-like sensation means forehead, temples, right, and the occipital region is where the patient is feeling some tightness or a band-like sensation. The moment you hear that the question is talking about band-like sensation, you know that it is a case of tension type of headache. Another word that is usually used is vice-like grip. Patients often come and say that ऐसा लगता है किसी ने टाइट से पकड़ा हुआ है, सर दबा रहा है जोर से. That's the usual description. So the moment I see these terms, I know it is a case of tension type of headache. Bilateral, band-like sensation or vice-like grip, no red flag signs, is tension type of headache. When red flag signs are ruled out, no need for imaging. Diagnosis is on clinical grounds. Once I made the diagnosis, how will I manage? Right? The tension type of headache management will require acute management and preventive. Acute, because it is mild moderate headache, all we need to do is give some NSAIDs, simple NSAIDs. Paracetamol is more than enough for most cases. Okay. And for preventive, the drug of choice is tricyclic antidepressants. To be more precise, it is the amitriptyline, which is the drug of choice. This helps the patient to tide over the bad phase of life where the tension type of headache is being triggered. Okay. How many days we give? We give it for around 90 days. Or 3 months. If they say that it is going to be a unilateral headache, then we have migraine and trigeminal autonomic cephalgias. So in such cases, we have to look at the duration of headache. The second important point is looking at the duration of headache. If the duration of headache, right? If it is unilateral, the possibilities are it is either migraine or it is going to be the trigeminal autonomic cephalgia. So in that case, what we should look at? We should look at the duration of the untreated episode of headache. So if duration is in the range of 4 to 72 hours, or whether it is less than 4 hours. If it is less than 4 hours, it is going to be one of the trigeminal autonomic cephalgias, and if it is 4 to 72 hours, it will be migraine. 4 to 72 hours, it will be migraine. Okay. Now what additional clues examiner will give if it is a case of migraine? He may mention that patient has aura. Patient may be having aura. So with or without aura. Second thing he will mention is patients with migraine often have photophobia or phonophobia. They also often have nausea and vomiting. The only thing I want you to note here is if the patient is having vomiting in migraine, it is going to be non-projectile. The moment I see a patient with projectile vomiting, I know it is something danger is there, because projectile vomiting indicates that there is raised intracranial tension. So these are the potential clues that the question will mention if it is a case of migraine. Again, diagnosis is on clinical grounds. We generally do not require imaging until and unless there are red flag signs. When it comes to management of migraine, the first line medications are generally described as NSAIDs. I forgot to mention another clue that examiner will give you is that these headaches of migraine are usually severe, moderate to severe, not mild to moderate like we see in patients with tension type. And because it is moderate to severe, usually patients describe it as pulsatile headache or throbbing. They will come and say कि सर फटने जैसा feel हो रहा है, throbbing headache. First line NSAIDs, but NSAIDs are not very effective. That is why the drug of choice is going to be triptans. And for preventive treatment, I mean this is all for acute treatment, and for preventive treatment the drug of choice is going to be beta blockers. Beta blockers are considered as the drug of choice. Preventive treatment is not given for all patients, right? It is based on Midas questionnaire. We have a questionnaire called as Midas questionnaire, which stands for Migraine Disability Assessment Scale. So first we will understand whether migraine is affecting the patient's quality of life. If it is not affecting the quality of life, probably there is no need for preventive treatment. Whenever he gets a migraine, he will take a medication. But if it is affecting the quality of life as assessed by based on impact on quality of life as assessed by Midas questionnaire, So if it is affecting, we need. If not, we don't need. Propranolol is the first line among the beta blockers. There are other drugs like topiramate can be used, venlafaxine can be used. So the list is long. I think we don't need to get into that detail as of now. So migraine is simple, right? Headaches lasting for 4 to 72 hours with or without aura, usually described as pulsatile or throbbing in nature, often associated with photophobia, phonophobia, nausea and non-projectile vomiting. Whenever question talks about it, you know that this is a case of migraine. They may ask you the diagnosis directly, or they may ask you what is the drug of choice for acute treatment. They might ask you what is the drug of choice for preventive treatment. Okay. And Midas questionnaire, they have asked full form 2 times. It stands for Migraine Disability Assessment Scale. So basically migraine, how much disabled it is making you. That is what this questionnaire assesses. If it is making you disabled, then it is better to prevent migraine from coming to you by giving you preventive treatment. Clear? Now if the headache is unilateral but duration is less than 4 hours, it belongs to trigeminal autonomic cephalgias. Sachin Rajput, absolutely right. It is my favorite drug because it causes weight loss. Topiramate causes weight loss, and that is why I prefer to use it, because most of my clients who come to me with migraine are middle-aged female who are overweight or slightly obese. So in such patients, when I use topiramate for migraine prevention, it helps them prevent migraine. It also helps them achieve some degree of weight loss. Okay. So if the headache is unilateral and duration less than 4 hours, it points towards trigeminal autonomic cephalgias. Now we call it as trigeminal autonomic cephalgias because here the distribution of pain is more in the areas distributed by the trigeminal nerve, right? And in addition to that, these patients have autonomic symptoms. They have autonomic symptoms. Now what autonomic symptoms I can expect at the face level? Mainly related to the blood vessel tone and activity of glands. So there will be flushing of the face. Lacrimation or tearing, and then vasodilatation of the conjunctival blood vessels giving you the redness of the eyes. Or conjunctiva, and then vasodilatation of the nasal epithelium giving rise to nasal stuffiness. So if you see all these symptoms being described in a question along with headache, you can make up your mind that this question is talking about trigeminal autonomic cephalgias. Okay. Now there are 3 types of trigeminal autonomic cephalgias. The first one is your cluster headache. That is the most common TAC. Cluster headache is the most common TAC. The second one is paroxysmal hemicrania. Paroxysmal hemicrania. And the third one is short-lasting unilateral neuralgiform cephalgia with conjunctival tearing, or short-lasting unilateral neuralgiform cephalgia with autonomic symptoms, or what we call as SUNCT or SUNA. These are the three trigeminal autonomic cephalgias. Now the last thing we need to know is how to differentiate between these three, right? So the differentiation between these three also depends on the duration. So usually cluster headache lasts for 30 to 180 minutes. Okay, paroxysmal hemicrania 15 to 30 minutes, and going by the name, short lasting, right? The SUNCT and SUNA, they last for 4 to 240 seconds. So when you look at the duration, it becomes very clear, right? If I tell you that, okay, I have a patient who has presented to me with bilateral headache and secondary headache is ruled out, then you know that I am talking about tension headache. If I say that I have got a patient who presented with unilateral headache, then the tension type of headache is ruled out. I am left with migraine and trigeminal autonomic cephalgias. Now I tell you that each untreated episode roughly lasts around 2 hours. In that case, migraine is ruled out because migraine lasts for 4 to 72 hours. So I am left with trigeminal autonomic cephalgias. Okay. So in these cases, the duration becomes the most important clincher. So I told you it is lasting for 2 hours. So where does it fit into? It fits into cluster headache. So then it becomes a clear case of cluster headache. If I say that unilateral headache, episodes lasting for 20-25 minutes, then it mostly becomes paroxysmal hemicrania. If I say unilateral headache lasting for only 10-15 seconds, then it becomes SUNCT or SUNA. In all these questions, as a clue, examiner will mention the presence of autonomic symptoms. In addition to that, there may be some additional clues for the diagnosis. What are those additional clues? If he is talking about the cluster headache, generally examiner mentions that cluster headache patients have seasonal variation. So there is some seasonality. Headaches appear in a particular season. And second thing they will mention is that alcohol precipitates. Alcohol as a precipitating agent. Usually these patients drink alcohol and after that the headache starts. So whenever you have a question where unilateral headache is there and alcohol is precipitating it, you can think of the cluster headache. You may say, sir, migraine also. Alcohol can precipitate, but most cases of migraines where alcohol has a relationship, it is not the alcohol intake. Today if the patient takes alcohol, tomorrow during the hangover period, migraine usually gets precipitated. But if I drink now, within next few hours, the cluster headache can get precipitated if I have the cluster headache. Okay, and if it is a case of paroxysmal hemicrania, then the clues that examiner generally gives you is that patients with paroxysmal hemicrania, they have excellent response to indomethacin. So if the question says that the patient has got indomethacin responsive headache, that means he is talking about paroxysmal hemicrania. Indomethacin responsive headache. Indomethacin responsive headache. Okay. Now the last bit of questions from the trigeminal autonomic cephalgia is what are the drugs of choices, right? So when we talk about cluster headache, in case of cluster headache, for acute treatment, the drug of choice is going to be oxygen. Drug of choice for treatment of cluster headache is going to be oxygen. But most effective treatment, more effective than oxygen is going to be the injection sumatriptan, or injectable triptans is the most effective treatment. But because there are side effects of vascular issues, we do not use sumatriptan. We still stick to using the oxygen. That continues to be the drug of choice. For preventive treatment, there are two things: for short-term prevention and for long-term prevention. For short-term, it is the corticosteroids. We give 1 or 2 weeks of steroids for the patient for short-term prevention, and for long-term prevention, the drug of choice is going to be verapamil, which is a non-dihydropyridine calcium channel blocker. If I have a case with paroxysmal hemicrania, for such patients, acute treatment is generally uncalled for. Preventive treatment, as it is highly responsive to indomethacin, we use the indomethacin. Indomethacin is the drug of choice for preventive treatment of paroxysmal hemicrania. And for SUNCT and SUNA, because they're lasting for few seconds. Generally there is no need for acute treatment, but if someone asks you, if there's an exam question asking you what could be the drug of choice for acute treatment, we can say lignocaine. Because the headache is lasting for few seconds, almost always it doesn't happen that patient will reach within those seconds to the hospital and get a lignocaine shot. But if you get a patient in the hospital and then the episode happens, maybe you can give the lignocaine. Preventive treatment, the drug of choice has been asked very recently, and that is going to be lamotrigine, which is an anticonvulsant. So lamotrigine is the drug of choice for preventive treatment of SUNT or SUNA. So this kind of addresses most of the points that can be asked as an MCQ from the headache, right? So don't miss out on taking a quick look at the reflexes, deep tendon reflexes, tone, tremor, movement disorders, right? Headache is as usual a standard important topic. Apart from that, rest of the topics that we have covered in neurology, most questions coming from those topics are relatively easy. Means they ask you to recognize what disease it is, and then they will ask you some simple straightforward question, like they will tell you a patient having bilateral ptosis, diurnal variation, symptoms becoming worse in the evening. Most of you know that, okay, this question is talking about myasthenia gravis. Then they will ask you which antibody is seen in this condition. So you will expect relatively simple questions from rest of the neurology. Slight complex questions are expected in aphasia, tremors and movement disorders. So please don't miss out on these topics. I'll see you tomorrow at 4 o'clock and we will continue with our cardiology.